Friday. Prof. Rez is here in the house.
Hello, hello,
Beautiful hello. By the way, if you can't tell the difference between us, that's okay. I made it a little bit harder now. Um, I didn't tell Rez this, but I also took another round of hair trimming, and I found the perfect, what I think, size of 1 millimeter blades. And I have an issue to tell you all about. So we're going to spend 52 minutes on this topic. And this topic is about needing to advocate for even numbers. Okay, even numbers do not have a lawyer, and I'm here to represent them. What the hell does that mean? Did you know that if you buy a blade to cut your hair, you can only buy protectors to keep the length at 1 millimeters, 3 millimeters, 5 millimeters, and 7 millimeters? And what systemic um, disregard to even numbers. It's so sad. As somebody who loves math, I feel like even numbers have been just like completely illogically dismissed. Why? Because it's sad that, there's no 2 millimeters and 4 millimeter blades. But more importantly, I think 2 millimeters is my sweet spot, but I will never be able to find it, which I think is so symbolic of life. You can get so close, but so far in many, many ways.
hello.
Rez, please take the mic away from me, please.
I was going to say, is 0 considered an even number or not?
Oh, wait, I don't know. I think 0 is, I don't know. What kind of mathematician am I? I have no idea.
Because I'm at a 0, but we know it's not an odd number, maybe an even number. And if you haven't listened to our episodes before, at this time, it's a good opportunity to turn off the camera and just go do something else, because the day has taken a turn for the worse. But we are so excited because one of our dear friends, one of our role models, both clinician, teacher, is going to be presenting us a case. Dr. Usha George, if you don't mind, just tell us, for those that don't know who you are, maybe just say a few words and give us updates on your kids too and what they're up to.
And most importantly, tell us what you think. Is 0 even or not?
I'm no mathematician, I'm afraid, right? So we've been Malaysia. I've been busy because we've had the 4th wave of COVID. So we've been struggling. But otherwise, I thought it would be a good time to catch up. Firstly, I would like to congratulate you, Reza, on the launching of your book, Finding Joy in Medicine. I bookmarked it. Definitely something I will get down to. All right. So the case I'm presenting today, there are 2 aspects. One is the clinical as we normally do. The second thing is there were lots of social a social aspect to the medicine of this. So I thought that it would be good to share with our junior doctors.
We are so excited, Dr. George. Thank you so much for the congratulations. Yeah, let's get into it. And I'm going to pass the mic to Robbie to discuss the first aliquot.
All right. Okay. So we have a 34-year-old female, history of altered mental status of 1 to 2 weeks duration according to her siblings. She's got associated right-sided weakness and also noticed bluish discoloration of her fingers and toes. That's the end of the first aliquot.
There's a lot to digest here, and maybe what I can do, since it was so juicy, not too surprising by Dr. George, maybe I can discuss the altered mental status and then pass the mic to Reza to reflect on the extracranial clues. And I think if you're studying encephalopathy, you want to pay attention to the age, and the age is important because age is a proxy of baseline mental status function. And we're lucky because that's almost universally true, but it represents a phenomenon that we want to study with every organ, not just the brain. And that key question is, what is the probability of baseline organ dysfunction? Why does that matter? A patient with CKD is much more likely to get AKI. A patient with COPD is much more likely to get a flare of shortness of breath. And a patient with brain dysfunction is much more likely to get brain dysfunction. All of these patients are more likely to get dysfunction of the organ with very minimal insults. And so here, the fact that this is a 34-year-old female gives us the inference that her brain likely functions very, very well, which augments the concern that she has encephalopathy. Meaning that the minor triggers that might result in encephalopathy in an older adult, like mild hyponatremia or mild constipation, are probably not at play. And there, with the absence of toxins as a cause of encephalopathy, almost every other cause of encephalopathy in a younger adult is a sinister one. But there's reason for further alarm here, and that has to do with another dimension of this, which is the focality. When you step back and you reflect on the mnemonic we share about altered mental status, which is MIST, M for metabolic, I for infection, S for structural, and T for toxin, most of MIST touches on extracranial disease, metabolic diseases like hypercalcemia, infections like pneumonia and UTI, toxins is the T, and the S, 1 out of 4, gives credit to intracranial disease process. But that completely flips on its head the moment you hear of one thing. And that one thing here is that she has associated weakness. The associated weakness may be asthenia from encephalopathy, but if it is in fact focal weakness, flips MIST on its head and makes an intracranial problem much more likely. So here, we're back in the world of MIST, but two things have changed. The age of the patient tells us that the likely baseline brain function is great, augmenting the concern for a sinister cause of encephalopathy. That concern is augmented even further by the fact that there is focality, which prioritizes an intracranial cause of encephalopathy, which is much less common than the usual extracranial causes, of which there are many. But there's another third clue to study here, and that's the bluish discoloration of the toes. And for that, I'll pass that on to Reza.
Poetry as always. And just to be clear, Usha, this was right arm weakness, correct? It was like focal weakness this patient had.
Yes, yes.
Okay.
Right arm and lower limb weakness.
Right arm and lower limb weakness. Fantastic. That's really important because, like Robbie said, when you have like a focal manifestation of weakness, then you have to go along the neuromuscular axis and try to ask, where can the lesion be? And remember, the left cortex controls the right side of the body, the left motor cortex. So can this patient be having a stroke that's manifesting as right-sided weakness? I think this is something that's going to be very important to consider. I have a patient on service right now who is 80 years old, has chronic microvascular disease, and her blood pressure dropped and she developed focal weakness. That's not because she was having an acute thrombotic stroke, but she was certainly having ischemia given the vulnerability of the microvascular disease that existed intracranially. So I think right away, when you see this patient, a young person, we don't have the past medical history yet, but you have to worry about a stroke, a tumor, some kind of lesion that's impairing function of that left motor cortex in controlling the right arm and leg. Now, to talk about the bluish discoloration of the fingers, reflexively, I think of hypoxemia when I see this finding. Now, you have to note that patients with Raynaud's can also have bluish discoloration of their fingers. That's usually a stepwise approach where you have white, where you have decreased blood flow, then you have blue where it gets congested, and then you have red where you get rebound hyperemia. But this isn't a patient who was at home, suddenly noticed her fingers were white, blue, and red. So Raynaud's is far less likely. In the acute setting, this is hypoxemia or cyanosis related bluish discoloration until proven otherwise. And right away, then you ask the question, two thoughts for the encephalopathy. Almost the encephalopathy is taking a back seat to the focal weakness where we're worried about a thrombotic stroke, and two, about some form of hypoxemia. And I started thinking, she's young. Could she have a shunt? Could she have severe lung disease that Dr. George hasn't shared with us yet? And we'll find out. But really, if I saw this patient in the ED, I would be doing a physical exam. I'd listen to the lungs, I'll check a pulse ox, and go from there. And I think another consideration too would be methemoglobinemia, where you can get cyanotic features, again, in that category of not having enough oxygenation causing the blue discoloration. So to summarize, yes, the chief concern is encephalopathy confusion, but our chief concern right now is the focality of her neurologic deficit and the bluish discoloration of her digits, suggesting some form of cyanosis. So I'm very interested in an O2 sat to go from there.
All right, good discussion. So the second aliquot, I'll include the rest of the history and the initial examination. So HPI, she reported no headache or blurring of vision, no bladder bowel disturbance. She had no fever, no recent trauma, no other past medical history. Socially, she's single, no significant family history, the youngest of 5 siblings, all involved in the fishing industry. She hails from a remote island. It's called Pulau Ketam. Pulau meaning island and Ketam means crabs. It's a sort of it's basically deals with seafood. She smokes 10 cigarettes a day, no alcohol, illicit drug use, not on regular medication, not on oral contraceptives. And she also gives a history of recent Sinovac vaccine, first dose, viral vector type, 1 week prior. Right, sorry. Okay, so I will move on to the initial general examination. So she appeared comfortable, no pallor or jaundice, normal temperature, blood pressure 120/80, pulse rate regular, 76 beats per minute. Her saturations were 96% on room air, no oral ulcers, normal systems in the terms of respiratory, cardiovascular, no murmurs, regular rhythm, abdominal examination, no organomegaly. Now, examination of the hands and feet, her peripheral pulses were present. I'm going to try and screen share. If I can, I'll try. Can I screen share?
You should be able to now.
All right. Okay, I'll try it now. Share screen. Okay. All right. Okay. All right. Can y'all see?
Yeah,
Yes.
we can see.
All right, okay. Okay, so the neurological examination, she was disorientated to time and place, slow to respond, struggle with answers, her pupils were reactive, extraocular eye movements were intact, no facial asymmetry, her right upper and lower limbs power 4+, normal reflexes, sensation present, and downgoing Babinski. That's the end of the second aliquot.
Very helpful. And Usha, did she have weakness at all or no weakness?
Well, she had mild weakness. She around
I
4,
see.
in a sense that when she was walking, she was sort of like dragging her feet to a certain extent. There
I
was
see.
mild weakness.
And it was symmetric, Usha, or was it right-sided?
It was predominantly right-sided.
Okay.
But in a sense that, yeah, it was predominantly right-sided.
Got it. All right, very, very helpful. I'll leave the physical exam for Robbie to tackle, and I'll just say a few words about the past medical history. And, you know, in medicine, sequence of events is as important as tempo of disease. The tempo, we sort of frame the patient as hyperacute, acute, subacute, chronic. The sequence of events is knowing exactly what happened or what preceded the patient's presentation. You have to be cautious here because you want to create two frames. One that includes the fact that she received the vaccination before the onset of symptoms, and two, one that doesn't include the vaccination. Because at the end of the day, if this is some kind of, rare reaction to the vaccine and you perform a cognitive autopsy, you'll say, oh, why didn't I include it? But if it's totally unrelated, you'll be like, why did I emphasize the vaccine? So I've noted the vaccine, my mind is tracking it. I'm not as familiar with that specific type of vaccine, but it would be as simple as just doing some search online to see if there could be a negative reaction. We were seeing some cerebral venous thrombosis with some of the COVID vaccines, but this, you wonder, could this have been a thrombotic milieu? But then the discoloration of the lower extremities, it just doesn't necessarily add up for me. So if this were an adverse reaction, it would be one that I'm not familiar with, but I'm open to that possibility. But my mind is going to frame it as if the vaccine is unrelated to see if there's any kind of organic etiology we can come up with that might explain this patient's presentation. And whenever you get the background data, you want to sort of filter it through the foreground. How does it influence our interpretation of the foreground? And yes, the fishing industry and the smoking. Smoking increases your risk for atherosclerosis. Without a doubt, she's still young and she might be more vulnerable to ischemia of her brain if there were an inciting event. So I put that in the background. Then you have the fishing industry. The fishing industry can be interesting in itself. There's different types of mycobacterial infections like marinum that patients can be exposed to, or something that's even more sinister and more fatal, Vibrio vulnificus. Vibrio vulnificus, I often think in people who are immunocompromised that come with like blistering skin disease and sepsis. We're not getting that flavor here. So to be quite frank, I don't know yet how to relate the fishing or exposure to fish and associated organisms to her current presentation. So in summary, where I am with this case is I'm looking at the sequence of events and risk factors, one being the vaccine, could there be an adverse reaction? Two being the exposure to fish, though there's nothing striking me or pattern recognition is not coming to my aid at this moment. Then I'm going to apply that to the physical exam where I'll pass the microphone to the mathematician.
Y'all, the physical exam localizes the lesion. What do I mean by that? The lesion here is in the vascular space. How do we know that? The rash that we see tells us that the problem is in the blood vessels. And it also tells us the nature of the problem. What we saw together was blue to purplish discoloration along with distal ulcerations. And that tells us that there is arteriolar occlusion. There is something blocking the arteries in the toes of this patient. And by inference, though not by certainty, the same thing is happening in her brain. You literally you are able to peer inside her body by looking at her toes. And I think that we should approach this as, why is this patient's arteriolars occluded? Making the inference that the same thing is happening into the brain, but often we want to prove that. And so the question here in the exam is, why are her arterioles occluded? The first thing is to ask two questions. What is occluding them? And where is it coming from? What do I mean by what? Things that occlude arterioles may be bland thrombus, but may also be infected material like endocarditis, maybe cholesterol deposits like the chat mentioned earlier, maybe metastatic cancer in blood vessels, such as that flicks off from atrial myxoma, maybe calcium that flicks off an artery or flicks off an aortic valve, maybe foreign materials like a fat embolism. And then it gets rare and rare. The two things you always have to consider, because they're common, are bland thrombus and and pus endocarditis. Less commonly so, things like cholesterol emboli and cancer, those are really in the clinical context. Endocarditis, why do people get endocarditis or endovascular infection is a separate analysis. Why do people get bland thrombi? People get bland thrombi for one of three reasons. There's something wrong in the blood that's flowing in the blood vessel because it has too much coagulation properties because of cancer, because of sickle cell disease, because of nephrotic syndrome, because of genetic abnormalities, or there's an issue with the platelet von Willebrand connection, such as too much platelet activation that as can occur with APLS or heparin-induced thrombocytopenia or vaccine-induced thrombotic thrombocytopenia. So there's issue with the blood, like cancer, issue with the connection between the blood and the vessel wall, platelets or von Willebrand's factor, and the von Willebrand's factor maps onto TTP as a cause. And then finally, issue with the blood vessel wall itself. Is the blood vessel wall too spastic, as can occur in vasospasm from smoking? Is the blood vessel wall inflamed, as can occur from vasculitis, which may be idiopathic or also related to smoking in the form of thromboangiitis obliterans or Buerger's disease? So I think you look at this and you're like, whoa, I didn't understand the syndrome before, but I know there's something wrong with the blood vessels. And the first question is what is it? Is it bland material or is it infected material? And in this case, you really have to worry about endocarditis. But most common, it's actually bland material. And that's when you have to do an exercise to try to localize lesion. Is it in the blood? Is it in the blood itself? Most common cause, cancer. Is it on the platelet, APLS, or HIT? Is it in the von Willebrand's factor, TTP? Is it in the blood vessel itself, vasospasm, vasculitis, dissection, so on and so forth? And here, that's the what. What is this material? The where is where did the thrombus originate? Did this thrombus originate in the toes, or did it originate proximally and shower the toes? And the more lesions you have, the more likely you are to have a proximal source of them. And the fact that both feet are involved and the brain is potentially involved prioritizes a proximal source like the aorta or the heart. So here the question is, what is going on in this patient's cardiovascular system? And I think that will be very, very informative. All right, Usha, back to you.
Okay, so what you've requested for is what you'll get. All right, we'll start off with some blood results. The hemoglobin is 12.2, total white 9.2, normal differential. Her platelet count is 90,000. She's got thrombocytopenia. She's got normal renal function, urea 8.1, creatinine 98 micromillimoles per liter, normal. Normal electrolytes. Her liver function is normal with an albumin of 42, protein of 79 grams per liter. Her inflammatory markers were surprisingly normal. Her CRP was 1.3, the normal range being less than 5. Her LDH, serum ferritin, and CKs were normal. HIV non-reactive. Her urine microscopy, no protein, no RBC, no cast. I'm going to move on to some basic imaging. We proceeded with an MRI of the brain, and it showed multiple focal areas of acute infarction noted in both cerebral hemispheres, in the cortex and subcortical areas. Her MR venography of cerebral vessels, there was no venous sinus thrombosis. MR angiography, short segment significant stenosis, and near complete occlusion of horizontal segment of distal left M1 of the middle cerebral artery. That's the MRI. Then because of her altered status, in fact, the thing that spurred her, she was slow in thought, but what spurred her siblings to bring, she's the only girl and all brothers. And what spurred her was that she actually came out of a bathroom in a state of undress. She forgot how to dress herself. So the deterioration in her orientation really was quite significant. So coupled with the fairly acute to subacute onset, we decided to proceed with a lumbar puncture. Her CSF examination, 8 WBCs, raised protein of 750, normal being 400, normal glucose. Her AFB, PCR, and CSF infective panel the preliminary PCR was negative. We then proceeded with an EEG, and it showed left temporal slowing. Finally, we proceeded with a cardiac echo. There was no thrombus or vegetation noted. And that's the end of aliquot 3.
You know what? This is so complicated, and I'm going to lean on my brother. I'm going to talk about the platelets and then leave everything else for Reza because I'm feeling cruel and unkind today, and I need his brain power. So thrombocytopenia is very interesting here, or it's completely not. What do I mean by that? We'll get to it. This is not just thrombocytopenia, though. This is isolated thrombocytopenia. And if the platelets are low in isolation, it means it is a consumption problem. When you only destroy platelets by themselves, it's very unlikely for the issue to be in the bone marrow because usually the other lines are affected as well. So what does isolated thrombocytopenia mean? It means the platelets are being destroyed. And the question is, where are they being destroyed? Are they being destroyed within the platelet itself, which commonly happens from infections that invade platelets like babesia, malaria, tick-borne infections, and certain viral infections? Is it because of an issue on the membrane of the platelet where an antibody is attached in idiopathic thrombocytopenia, ITP, or in a specific antibody like heparin-induced thrombocytopenia or APLS? And least commonly of all is an issue in the environment which bathes the platelet in, and that's where a microangiopathic hemolytic cause exists. But the problem with thrombocytopenia is it can be non-specifically depleted as part of a systemic inflammatory response, no different than a high CRP, high ESR. So here, it's hard to fully drop your anchor on thrombocytopenia, but you have to make note of the following contrast. Patient is clotting, and has low platelets. Most patients with thrombocytopenia are bleeding. Why is this patient both clotting and having low platelets? And that prioritizes the evaluation for the microangiopathic hemolytic causes, which cause a thrombotic thrombocytopenia, makes immune thrombocytopenia the most common cause very unlikely. Most patients with ITP bleed, prioritizes vaccine-induced thrombotic diseases, as well as APLS, but also gives a little bit of credit to the infections that can do it, which we talked about earlier. So here, be careful about the platelets. They may reflect no diagnostic value and thrombocytopenia of inflammation, but in the context of thrombosis, you have to worry about MAHA and you have to worry about APLS. I'll pass the mic to Reza for the rest of it.
Hey, Robbie, that was brilliant. I love the way you talked about thrombocytopenia and how we often expect bleeding, not thrombosis. And I also want to highlight what you did on the physical exam was corroborated by the MRI finding. You said, look, and if we go back to even the HPI, encephalopathy, focal weakness, and tissue discoloration, bluish discoloration, it's telling you that there's local ischemia at different regions that is bringing this on. And even the encephalopathy can be explained from diffuse local ischemia that's intracranial. And then Robbie looked at the physical exam and said there has to be something within the vessel that's occluding perfusion in the digits and also in the brain. And then Usha shared with us the brain MRI, which corroborates Robbie's initial hypothesis from the physical exam. So our question now is, what is causing these lesions, this sort of embolic phenomenon in the brain, in the digits? And really, when you're approaching sort of widespread embolic phenomenon, you just have to follow the path of blood. So for example, you can start in the venous system, and you ask the question, how can someone with a clot in the venous system have evidence of arterial thrombosis? Well, what if they had a PFO, for example, and thereby you had a paradoxical embolic phenomenon? Keep following the vein into the right ventricle, the right atrium, the right ventricle. Of course, if there's a lesion there in a PFO, yes, you can get sort of a paradoxical phenomenon. Then come to the left side of the heart. So everything is yelling if there is pathology and if it's from the heart, it's on the left side. So what can happen on the left side of the heart? Well, you can have masses like atrial myxomas, or you can have vegetations, which can be infective and non-infective on the valves that then leak into the arterial system and then occlude the relative territories that Usha has presented here. So then you pause at each of these. Is there a risk for this patient to have a DVT? Well, some patients get DVTs for unclear provoking factors. So it would be interesting to know if the patient had an ultrasound of the lower extremity, or if the echo was done with a bubble to see if there's some form of shunt that may exist between the right and the left side of the heart. But note that 15% of the population might have a PFO, so it doesn't prove that the lesion was in the venous system and then paradoxical embolism. Now, can this patient have infective endocarditis? Remember, endocarditis can present subacutely and you'll be fooled for endocarditis, and certainly can have sort of embolic phenomenon, but nothing about this patient's presentation is actually suggestive of an inflammatory process, of an infectious process. Look at the white blood cell count. Look at the ESR, the CRP, the albumin, no hits for inflammation. So I think infective endocarditis becomes less likely. Yes, you could have non-infective endocarditis. And in non-infective endocarditis, the vegetation, like if it's, for example, lupus or cancer related, they actually don't cause as much destruction of the valve, and they're just sitting on top, and they're very prone to sort of have embolic phenomenon. But that's a possibility. And yes, we'll figure out if this patient had an ANA sent as our screening test for lupus. And because we're worried about APLS and those two conditions can coexist, it is worth sending that ANA complements in a double-stranded DNA. But I'm just not really getting a strong hit for lupus. There's no other manifestation of lupus. If you go back to the physical exam or the background data, nothing is yelling. And if you look at the urine, there's no proteinuria. So it would be an odd manifestation. And oftentimes we can see lupus just present with nephritis, but for lupus to just present with, intracranial thrombosis and thrombocytopenia, I think less likely, even though it can always be lupus. Then once you leave that left side of the heart, now you can think about hypercoagulable states. And this is where we have to bring the thrombocytopenia front and center. A platelet count of 90,000 in someone who's 34 is low. The first question becomes, is this isolated thrombocytopenia or is this bicytopenia? You say, wait, Reza, what do you mean bicytopenia? Everything is blue there. How can this be bicytopenia? What if this patient had compensated hemolytic anemia, meaning that she has a healthy marrow, she's young, she's developing reticulocytes that's making up for the lysis of the red blood cell. So in such a patient, you still have to consider a microangiopathic process. So you want a peripheral smear. You want to look at the AST as normal, which might be a marker of red blood cell lysis. You want to make sure you send the LDH. You just basically want to make sure that there isn't anemia and thrombocytopenia. Because if it's anemia and thrombocytopenia, then you really have to think about TTP in microangiopathic hemolytic anemia. I honestly am not getting that flavor here. And don't wait for the pentat of TTP, which is neurologic, renal, fever, thrombocytopenia, schistocytes. Look for the triad of thrombocytopenia, schistocytes, and elevated LDH. What I'm just trying to say is you don't want to dismiss this hemoglobin as normal until you're certain that there's no hemolysis, because that will be of utmost importance. Now, when you see this isolated thrombocytopenia, I'm still going from that frame because it's thrombocytopenia and thrombosis, the way the mathematician laid on a platter for our brains to think about. You want a peripheral smear. This is your first branch point, because if you see giant platelets on that peripheral smear, then you know that this is a peripherally consumptive process. And I'm feeling 80% confidence that this is peripheral consumption of this patient's platelets. And if that smear shows the giant platelets, strengthen that hypothesis. Another thing you can send is the immature platelet fraction. That is equivalent to the reticulocyte count we send for the hemoglobin. So if that IPF is elevated, it's further consistent with the peripheral destructive process. So now we have to ask the question, assuming there's no hemolytic anemia, what causes isolated thrombocytopenia and thrombosis? So this is where you know, if someone has been exposed to heparin, would be the classic example. Heparin, but this patient has no encounter with the health system. So there is no heparin exposure. And although I'm not familiar with vaccine-associated induced thrombocytopenia and thrombosis, but maybe that would be a similar mechanism. I don't want to anchor on that, but that's definitely on the DDX. And then Robbie mentioned antiphospholipid syndrome. And with antiphospholipid syndrome, we're going to send the lupus anticoagulant, the beta-2 glycoprotein, and the cardiolipin antibody. Can this be APLS? It can be a APLS, and maybe it could be background of APLS that's triggered by the vaccine. Remember, the vaccine may cause an immune-mediated phenomenon and exacerbate an underlying autoimmune process. Now we bring our attention to the CSF. The white blood cell count of 8 is telling you there isn't much meningeal inflammation. The glucose is normal. This is not a bacterial meningoencephalitis. The CSF can be normal, and you can still have encephalitis, by the way. But then you see that the protein is elevated. The protein being elevated can tell you that there might be some kind of immune-mediated demyelination within the CNS, which might be consistent with the hypothesis that Robbie shared, that the vaccine has revved up the immune system, causing the thrombocytopenia, causing the thrombosis, causing the increase in protein in the CSF. The other way you can get protein in the CSF, you can always perform an IgG index to know if we're dealing with intrathecal inflammation, which usually doesn't leave a signature in the systemic system or not. But where I am right now, by the way, it's almost like the albuminocytologic dissociation that we see with Guillain-Barré, which is the demyelinating process. Where I am right now is vaccine in a healthy patient, isolated thrombocytopenia, unlikely to have concomitant anemia. Here, with diffuse thromboses, nothing pointing to the venous system, nothing pointing to the heart, most likely intravascular. And I think you have to entertain the idea of just the immune system being revved up by this vaccine, but you'll work up for lupus, you'll work up for APLS, you'll still consider something that, because remember the TTE has to go through the sternum, so you might miss the vegetation, but I think that's less likely. I want a peripheral smear, I want an ANA, I want the APLS antibodies. If those are all negative, then we go and look and do a Google search on this vaccine.
Right. Okay, your wish is my command. Right, we'll start off with the peripheral smear. No schistocytes were seen. There was no comment made on the size of the platelets, but clearly there were no schistocytes seen. All right, now the direct Coombs test is positive. Her complement levels were low. C3 0.71 decrease. Her C4 0.13 decrease. So as Anne-Marie requested, both the complement levels were low. Now, I think her anti-nuclear factor, ANA, was raised at 1:1,280. Double-stranded DNA was negative. Her ENA, anti-centromere protein B antibody, was strongly positive. I'll end this aliquot with her coagulation. She had a normal prothrombin time, but she had a prolonged APTT at 45, normal being 25. The next aliquot will reveal the diagnosis.
Dr. George, you always impress, my friend. I am going to pass the mic to Robbie because I myself am tired of hearing myself speak. So Robbie, take us home, my brother.
You know, middle-aged, actually, to be honest, young people don't get many diseases, but some of them are so devastating. And I think you're seeing a signature of a disease phenotype here. And I think it goes back to what Reza was telling us. He's like, when he took us on that magical journey from the veins to the heart to the blood on the left side. He said, this is where thrombosis and thrombocytopenia come together. And, think about it. So much of the time when you're dealing with thrombocytopenia, you're wanting to transfuse platelets, you're worried about bleeding. Sometimes you'll even give patients bowel regimen when their platelet count is 5, so they don't have intracranial hemorrhage when they actually go to the bathroom, which has been described. But here you are saying this patient has a platelet count of 90,000 and is thrombosing. And that is a very rare combination and a cause of concern. And that's another counterintuitive test has really shed light on the most likely diagnosis, I think, and that's when you have a prolonged PTT and the patient is thrombosing. So what causes a prolonged PTT? The most common causes of a prolonged PTP are medications, liver disease, and DIC. Medications like anticoagulants, which the patient is known to be prescribed, or herbal supplements that have anticoagulant properties. Those are the three most common causes. But what is the most common cause of a PTT prolongation and thrombocytopenia? APLS. Most cases of prolonged PTP are married with bleeding. Here you have a prolonged PTT in the face of thrombosis, and that's very concerning for APLS and antiphospholipid antibody syndrome. Most cases of APLS, about 50 to 60% of them, are idiopathic primary APLS, but the 30 to 40% are secondary to autoimmune disease, the most common of which is systemic lupus erythematosus, or lupus. And here, a positive ANA, low complement levels in the context of APLS are concerning for that. The wrench in the fork is that the strongest association I have with anti-centromere antibodies is actually that with limited scleroderma, or CREST syndrome. CREST stands for calcinosis Raynaud's, which Reza mentioned very early on, esophageal dysmotility, sclerodactyly, and telangiectasia. So what are we confident about? I think that unfortunately it looks like this patient has APLS, and we can talk about the diagnostic testing for that at some point. And it appears that an underlying autoimmunity seems to be the driver of that. The most common underlying autoimmunity, lupus. What's consistent with lupus? Low complements. What's less consistent with lupus is the antibody anti-centromere, which I associate more with CREST syndrome. But I wouldn't be surprised if there's an autoimmune milieu here, to use Reza's now famous word, or that there is actually lupus with anti-centromere antibody, and I have to learn more about that. But Rez, what do you have to add, teach, modify before we pass the mic to Usha?
A 0.
All right.
All
Usha.
right. So the final aliquot, right? Yep. So her mixing test was done, and that did not correct. And her lupus anticoagulant was positive. So our final diagnosis was an autoimmune vasculitis with a scleroderma overlap with secondary APLS associated with cognitive impairment. She responded to pulsing with methylpred, low molecular weight heparin, and eventually was transitioned to cyclophos and warfarin.
Usha, I am just blown away. And I'd love for you to reflect and teach us, like, what was your takeaway from this case? And if I just can do in 1 minute a quick cognitive autopsy, I think just like that first aliquot was so rich. It was like diffuse brain injury, focal brain injury, local digit injury, all linked through some form of ischemia. And then finally, we knew something was happening intravascularly. And I always find it difficult to interpret some of these serologic tests, like the Coombs test, when their immune system is so revved up. Like I feel like you can get false positives, and then there's these overlap syndromes. But would love to learn from you, Usha, as to like what your takeaway is, what do you want to teach us before Kirtan takes the mic.
Right. All right. I think I would just like to take 5 minutes to elaborate on the social aspect of this case, because I think VMR does sort of clinical teaching so well. And so the thing about this girl is that we mustn't take things at face value. So the initial history, the localization of the lesion in someone with altered mental process. Now, her brothers, of course, said 1 to 2 weeks, but time, as Aaron so rightly teaches us, it's the time course. And when you actually, because her work involves weighing fish, she's a fishmonger, she lives by the beach, and she naturally, so when we actually delved into the history, over the last 6 months, she was making very unusual errors in terms of weighing and charging and collecting money. So I think the actual disease process happened a lot longer. And when we actually delved into the history, the time course really was for the last 6 months. So I think that's sometimes important that when someone gives you a history, we probably will need to sort of delve into a bit more to really clarify, to be certain. So I think we were misled the initial time when she came in thinking that it was probably an acute meningoencephalitis sort of pathology. The second thing is, how much time did we have to investigate this girl? I think when she walked into our door, we realized that we really needed to have a grip on it. Why? Because she was a young girl, she had altered mentation, and she had thrombocytopenia. So as we are taught, I think there is an episode of the Clinical Problem Solvers. I think it was by it was an episode of vaginal bleeding, and Dr. Rory May, if I'm not mistaken, she's a hematologist from University of Alabama. She's brilliant. She's done, I think, 2 episodes of hematology on Unremarkable Labs. And what she had emphasized, low platelets, what are the emergencies? Of course, TTP, that was top of our mind. But the peripheral smear, we quickly had a look at it. The other thing of HIT, but you're right, Reza, she did not come into a hospital environment. Although really that episode where Jory May presented, it was someone who had HIT without heparin. It was apparently, it can happen post-knee replacement, etc., in about 10% of patients. And really, the whole concept is, as we go about medicine, there are new diseases that come across. And naturally, in this case, it was her viral vaccine. So we were alarmed because she had the vaccine a week before. A young girl comes in with headache, low platelets. But then on taking the history, and we realized that the history actually went a lot further back before the vaccine. So we were not so concerned about VVIT. All right. So that's about platelets. The next quick thing was the point about, Malaysia, we are sort of a multicultural society. I mean, for instance, in my case, very quickly, my mother is Chinese. My grandparents originate from China, and my father is Northern Indian. And my village is actually in Dehradun in India, since a lot of kirtan, etc., all from India. But I'm Malaysian. So the point that I'm trying to stress is, she came from a very traditional Chinese family in a very remote fishing village. Now try telling her 4 anxious brothers what autoimmune meant. They just could not conceptualize what was happening to their sister. So naturally, they quickly thought that she was being charmed, or so they wanted to take AOR discharge. And we had to persuade them to their line of thinking. So naturally, they wanted traditional medicine, which of course we could not allow, but we even brought in, just for them to accept that something was being done for their sister. So we brought in an acupuncturist team so that they will conceptualize that something was done for their sister. And we didn't think that it would affect our treatment very much. So dealing with the cultural aspect of things sometimes, I think, is an important aspect that maybe is not regularly taught to young doctors in medical school. So that was one thing. Now, the other small thing was sometimes, we knew that she had to be transitioned to warfarin because of her APLS. But the fear of, as doctors, we are taught, even if you do nothing, do no harm. And we were sending this young girl back to a village that there was not a clinic in sight. And how do we prescribe warfarin, which needed monitoring, dosing, etc. So we got our peripheral social team to get onto the village and study the logistics of it, work out something. So again, as doctors, it is easy for us to prescribe medicine according to protocol, but the practicality, I think it is useful to look into it. So I think we were also troubled by how we were going to prescribe her warfarin and make sure that she was safe taking it. The last point is, as in any service, it is all in terms of cost. Now, I'm not familiar with the health system in the States, but in UK, yes, because I was trained there. And in Malaysia, I work in a private hospital. She had very limited insurance. Now, the problem is that her fingers were really getting, they worsened to the point that they were almost pre-gangrene. So we needed that, we realized that she needed prostacyclin infusion, really. And that cost was phenomenal. So the final point is, as private doctors, we had to liaise with the government sector, which is, as usual, was really packed, and she was way down the list. But we negotiated and, to sort of give preference to her case. She's a young girl. We didn't want her to lose her digits. And eventually they consented and took her over and she had her prostacyclin infusion, which was very expensive. So again, there's a negotiation between hospital systems. So one of the reasons I wanted to highlight this case is, as doctors, yes, it is very important to remember what we call clinical schemas. But I think what makes our job special, unique, and really fulfilling, that few people outside the realm of our field, that it's a lot, there's so much more to medicine that I'm sure you would have experienced from Prof. Red's book. And ultimately, when we sorted out all the social issues, I think that gave us the most satisfaction with this case. Thank you.
I think it's literally impossible to reflect on the masterclass that just happened. And I think, and to put it briefly, I think that if you look at this screen, it is simply the screen that we have right now. It is simply just physiology and biology. And we have to master that for sure. But Usha, well, I think what you're teaching us is you're a master of nothing if you just know this. You have to be a master of humanity and the context in which all this is occurring, both the human being in which it's occurring in their lived experience, but also the world that surrounds them, their socioeconomic status, their cultural heritage, their own peculiarities, their families' peculiarities, government funding. I mean, I think that this is what we did today, Reza and I, is only half the battle, and the other half of the battle is I think why our job is just limitlessly humbling and limitlessly complex, but also limitlessly satisfying, especially when it's done well. And I'm not the least bit surprised, and I think I speak for Reza and everybody, that it is just so wonderful to hear this great story of how somebody with terminal prognosis really gets care despite all the barriers, both the morbidity of the diagnosis itself and also this barriers that you all had to own, create and artfully overcome. Every time you're here, it's humbling every single time. And I have a lot to reflect on, both from this case and from what you just taught us. And really can just only say thank you. Thank you for gracing us with your presence and teaching us much more than is on the whiteboard right now. But as our cultural tradition, I'll go back to my dear friend Kirtan, who you referred to reflect on the medical journey one more time before we say goodbye.
Yes, so for the sake of time, I will try to keep it brief and short. And first of all, thanks to Dr. George for presenting amazing case. I think we should have her every 2 or 3 weeks because she just brings VMR to another level. So thank you for that. And also RLR for amazing discussion as always. So we started with the altered mental status and the bluish discoloration of the toes. So Reza told us that if we have focal finding, if we have weakness, then it points to a possibility of stroke, and that's always sinister. But if it is not focal finding and it's still pointing to cerebral thing, then we have to forget about the mist, because mist is not likely to account for everything. And then if we throw in the another symptom, that what about blue toes? Then is it related to embolic phenomenon? Is it related to cyanosis? I mean, the patient might have a shunt in the lungs, patient might have idiopathic pulmonary fibrosis, anything which can cause this presentation. So that was our first aliquot. Then we gathered clues from the history and physical examination. So the Reza told us that of course vaccine is there, vaccine-induced thrombotic thrombocytopenia is there, but is that enough? Should we lay our anchor on that itself? So the answer is clearly no. We have to consider other findings, right? So we focused on smoking. Can smoking cause atherosclerosis? We focused on the marine history, right? All the esoteric infections, pulmonicus, non-tuberculous mycobacteria, all that sort of things. From the physical examination, we got clear hint that this is definitely some sort of embolic phenomenon, because only few toes were involved, not the entire extremity was involved. So we were sure that there has to be emboli somewhere. So in the third aliquot, Rabi mentioned that what can be the source of emboli, right? I mean, is it infective endocarditis? So it is septic emboli, or is it the bland emboli? And if it is indeed bland emboli, what can cause that? So atrial myxoma can cause that, cholesterol embolism can cause that, right? Calcium can cause that, all those things can cause that, but those are esoteric entities. So we should stick to the common entities, right? And then we get the lab findings. And in the lab findings, we have the evidence of thrombocytopenia. And then we go down this, rabbit hole, that why thrombocytopenia, why clotting, why? So there are only a few things which can cause that. So heparin-induced thrombocytopenia being one of them, vaccine-induced thrombotic thrombocytopenia being another one of them, and then whole the MAHS spectrum, so-called microangiopathic hemolytic anemia spectrum. In that, we include not only HUS and TTP, but even catastrophic antiphospholipid antibody syndrome, scleroderma renal crisis, and all other vasculopathies which can present in this manner. And lastly, very briefly, I want to mention about antiphospholipid antibody syndrome related manifestations, because I love rheumatology. So APLA can cause so many things. And one of those things is livedoid vasculopathy. So it is a kind of vasculopathy which is limited to skin usually and can present as livedo reticularis and embolic manifestations. That's the one part. Furthermore, apart from the clots and everything, APLA can itself cause transverse myelitis, meningoencephalitis, and all other things, because it can cause T2 flare hyperintensities in the subcortical white matter because of the small vessel vasculitis that APLA can cause. So it can mimic the demyelinating disorder, both on imaging studies as well as the clinical findings. And lastly, just a few weeks back, a case was published in Mayo Clinic Proceedings that APLA can exist with something known as Sneddon syndrome, which stands for SNEDOON syndrome. So it's a kind of polyarteritis nodosa-like symptom, which can present with strokes everywhere, which can present with cutaneous manifestations. So it has been documented that people with APLA can develop Sneddon syndrome later in their life, and it's a vasculitis, so I love it. So I wanted to mention that just for the sake of complexity. And yeah, thank you so much for everything, and hope to see you next time.
Hi, everyone. Kirtan, I thought I was listening to Robbie teach. That was spectacular.